All right. Hi, everybody. Thank you so much for being with us today. My name is Kristen Casado. I am the Director of Communications for the Connecticut chapter of the Alzheimer's Association, and also have the distinct pleasure of being something called a research champion. I'm not a doctor, I'm not a nurse, I'm not a researcher, but I get the information that we as the Alzheimer's Association are funding and what we're focusing on and the trends in research, and am able to share it with you. There are about 30 of us research champions across the country who are working for the association in various roles to kind of bring all the different roles together, all the different insights and aspects. So it's great. So we just came back from a big conference that I'm going to talk about. So I'm pretty excited to share about that. I just want to give a wave to Dr. Gettel, who will be in with us. He's here. He is one of our funded researchers, and he is going to be sharing with you in just a few minutes after I do an overview, some of the things that he's really looking into, which I know that you're all here because it's such an interesting and different topic. And I love that this is out of the box, right? If you're not too familiar about the research that we fund as the Alzheimer's Association, this is an example of something that you may not think of. You may think, oh, it's just drugs, or it's just way preclinical, or it's something, about amyloid or tau, but this is something different. This is for caregivers and the emergency room and that experience, and how to make it better for everyone, and what people need. So it's really great. So what I'm going to do is I'm going to start sharing my screen, and I'm going to present a bit of an overview. All righty. Can you guys see what I am showing? Give me a thumbs up if you can see that. Perfect. Okay. All right. And again, if you're just joining us, the questions are going to have to go in the question and answer and not the chat today, because I did something. Yeah, it doesn't allow the chat to be open, which we'll fix before the next one. So again, just to share with you a little bit of an overview about what we do as an association. So that's the symbol that you see quite often, right? That is the a person and a beaker, the brain and the beaker, people and science. That is our symbol, that is in our logo. And it's really that as we take care of those who have this disease, as we take care of those who are worried about this disease, as we take care of the caregivers and offer support to all of those, we're also at the same time pushing research forward to really get towards these new treatments and cures. And I wanted to level set a little bit and just kind of share with you what this is, the difference between dementia and Alzheimer's. It's a big question a lot of folks ask, right? What is the difference between dementia and Alzheimer's? She has dementia, but doesn't have Alzheimer's yet. What does that mean? So dementia is the umbrella term that's used overall to talk about the symptoms that the person is experiencing. What are some of those symptoms? Well, if you know some of the signs, then you know some of those symptoms, right? It might be repeating the same story over and over again, getting lost coming home from familiar places like the grocery store, really having some behavioral or concerning issues because of the fact that they're frustrated and confused, and the brain isn't working, and the brain mouth and is it working enough? You're not able to say the words that you want to have word finding issues, for example. So it's really the different symptoms that you may have happened to you. That's what dementia is. It is caused by Alzheimer's and other forms. Okay, so Alzheimer's, when you're diagnosed with dementia, Alzheimer's is the most common type. So between 60 and 80% of those diagnosed with dementia are diagnosed with the Alzheimer's type. Then you've got other types like vascular dementia. You may have heard of Lewy body dementia. My mother had that, so I'm pretty familiar with that type. Frontotemporal, a mixed dementia. These are the biological changes in the brain, okay, that cause the dementia. So that's the difference between Alzheimer's and dementia. And just to share with you guys, we are the largest nonprofit funder of Alzheimer's and all dementia research in the world, not just in the US, in the world. And then you may see some things talking about what we say is at any given moment, research is happening in the world that we are a part of because we do fund all over the globe in all those time zones. At present, we are funding 950 projects in 48 countries to the tune of $310 million. And proud to say, I know some of you guys are from other places in New England, but here in Connecticut, where we are based, we have about Oh, here's the this is the New Hampshire slide. I apologize. We have about $2 million here in research. Let me go back one more. $2 million here in research funded right here in Connecticut at places like Yale and places like UConn and UConn Health. Let me just give you some of the different examples of some of the things that we're funding. Up at UConn Health, we are funding someone who's doing a study on apathy and dementia, or depression and dementia, that combination, and then add in COVID. So he's doing that kind of extensive study. There is someone at Yale who is doing something about the really unique types of dementia. So people who are coming forth with some language issues or visual issues, those types of dementia. You have Dr. Cameron Gettel, we'll talk about that in a moment. You have people who have done studies getting closer to a blood test, right? We know that there are not real easy ways to diagnose this disease, but wouldn't it be fantastic if some of the doctors have more tools in their toolkit, and one of them would be a blood test to show that either you're at risk or you have this elevated Alzheimer's or elevated amyloid. So speaking of research, we just got back from the Alzheimer's Association International Conference, and this is a giant, amazing event that was held in San Diego, and about 6,000 people were in person and about 4,000 were online watching. And what this is the biggest and brightest minds in dementia from all over the world coming together to share all their information. So it really was a fantastic week, and lots of really great research came out of that. And one of the big stories was really about COVID. And I would just like to share with you guys that when COVID, it continued on, and everyone realizing that it's not just a quick thing, right? It's something that may go on for quite a while. The Alzheimer's Association created and funded a consortium of 40 different countries, all coming together to study long COVID and long COVID in the brain. What does it mean? So some of the results are coming out year after year. And this is an interesting one that came out talking about COVID, showing that the persistent loss of smell post-COVID may be a better predictor of your cognitive impairment than how severe your COVID sickness was. What does that mean? Well, if you think about it, persistent loss of smell probably due to being inflamed, right? Inflamed, that goes, could potentially be an issue in the brain, inflammatory. We're looking into a lot of inflammation as a possibility of one of the issues and one of the things to really go after to understand this disease. So if you still have a loss of smell after COVID, it could be that we are going to see more more dementia cases. Being female, not working in lower socioeconomic status during the pandemic, also associated with more cognitive symptoms. But something positive, a positive life change, may reduce the negative impact. So if something really good happened to you during COVID, if you had really wonderful times with your friends, if you had a job change, if you were able to have something really positive. So it's just interesting. Just know that research into COVID is absolutely continuing. Also, major research into racism and how that may negatively impact your memory. And really the bottom line is talking about key takeaways. Racism is a trauma that leads to stress. And again, we're talking about inflammation, right? And inflammation is a known risk factor for cognitive difficulties. So is that something to really think about? And absolutely it is, because, people who have had institutional racism or interpersonal racism, it was really associated with lower memory scores. It is a trauma. So there's very interesting studies about race and racism from AAIC as well. And this is also an interesting one, right? Think about ultra processed food. Now, we know that we should be eating right, but we also know what we like and what tastes good. And unfortunately, ultra processed food, which is a lot of things that you may really like, we're talking about soda, we're talking about chips, we're talking about fries, we're talking about cereal, cookies, ice cream, which makes me so upset. Bottom line is they looked at 10,000 people, and if 20% of their diet was made of these ultra processed foods, they had a 30% faster decline in cognition. So 10,000, 20, 30. Look at it, 20%, that's 1/5 of your diet. Like look at your one day out of 5, right? Your Monday through Friday, for example. So what is this saying? This is saying we probably knew some of this already, but here's some more stats and more really evidence that we really need to start to eat a lot better, and everything in moderation, of course, but really incorporating lifestyle interventions could be helpful. And here's another example. We found out earlier that up to 40% of dementia cases could be prevented or delayed by targeting modifiable risk factors. What's a modifiable risk factor? Modifiable is something that you can control, right? So that means increasing your physical activity, incorporating the Mind or Mediterranean diet into your nutrition, right? Those green leafy vegetables, if it's accessible to you, right? We know it's hard, and we know that there's a lot of policy issues and need for change to make sure people aren't in these food deserts, for example, but making sure that access is available to all. So healthy diet is important. Cognitive and social stimulation is very, very important, and especially important during COVID. So if we can really focus on different ways to reduce our risk, that could be helpful to reduce our risk of having dementia. So we are, as the Alzheimer's Association, funding and running something called the US Pointer Trial. This trial is fabulous because it is looking at people who have what they're called suboptimal lifestyles. Okay, so people who may not be exercising or eating well, they may already come forth with some of those risk factors like cardiac or blood sugar, right, diabetic kind of issues. Looking at 2,000 of them, you can see between 60 and 79, recruiting from 5 parts of the country. The one closest to us here in New England is in Rhode Island. And they're looking at these folks, and they're going to study them for 2 years. And they're going to study the amount of physical activity. They're going to have them go to the YMCA. They're going to help them with their nutrition. They're going to do this health coaching and engagement, and then do all these different things, and then check on them, right? Check on them as we go through. And then if in fact, do these things work to reduce risk? And we think that the answer is going to be yes. Good part about this is that we're really pushing to make sure that everyone is incorporated and included in this study. More than 1,300 who recruited, and 25% of them are from underrepresented populations, because we need to learn more about the underrepresented populations and why, in fact, this disease is more impactful in those different cultural region. We're talking about Black African Americans 2 times as likely to develop Alzheimer's as whites, and Latino Hispanic 1.5 times as likely. So we know some of the reasons why. We need to know more, hence the reason why we really need to have inclusion in clinical trials. Speaking of clinical trials, Trial Match is what we do at the Alzheimer's Association. We really have folks try to get involved in clinical trials, and it's super easy. I liken this to a Match.com, which is a dating site for those of you who've been out of the game for a while. Don't ask me how I know. And we liken this to Match.com, in that you put your information in, and up pops your possible matches for trials in your area. What does that mean? That means that your information is never given out. It's up to you. They don't see your stuff. You see what's available to you, maybe in your region. And then you can reach out and say, I'm kind of curious about that. And the trials range from answering a few questions once every few months online, to being involved in an exercise study, to having blood draws, to getting involved in drug trials. So lots going on. Please inquire about Trial Match. Any questions about science at all, including all our funded researchers on the Science Hub app. If you have room on your phone for another app, we would really love you to do that. It's going to answer a lot of questions that you have about what's going on. And then, of course, I would be remiss if I didn't share that we are in walk season. We are here, ladies and gentlemen. Tomorrow is September, and the first of our several walks are on September 24th and 25th. It's our big weekend. We have 6 walks in Connecticut. There are walks all over the country. There's 600 of them. We would love for you to join and take part. It's a beautiful event, but also the money raised helps fund research. So I think that's really critical as well. So I am going to stop sharing, and I'm going to share with you one of our very important funded researchers. Class of 2022, I like to say, is the funded research, not coming straight out of college. I'm saying as the funded researcher. Dr. Gettel is an assistant professor in the Department of Emergency Medicine and a clinical investigator at the Yale Center for Outcomes Research and Evaluation. He can explain that to you. Dr. Gettel, please take it away.
Awesome. Thank you, Kristen. Excited to be here, and I'm going to try to match your enthusiasm and energy. Let me share my screen, and then we'll get started. Okay. Okay, Kristen, maybe could you or someone respond back just to make sure that they can see my PowerPoint slides?
Yes.
Okay, all right, perfect. So I am thrilled to be here and to have the opportunity to talk with you all. As Kristen said, my name is Cameron Gettel. I am an emergency medicine physician, researcher. I'm here in New Haven at Yale. And I am fortunate to, for the past year and the upcoming year, to be funded by the Alzheimer's Association to do some work at the intersection of dementia, cognitive impairment, and acute care in the emergency department. And so in talking to Kristen, I was sort of trying to understand the audience, sort of going forward to make sure this is most salient, most pertinent to the audience. And I understand the audience to be care partners, persons living with dementia, researchers, potentially clinicians. And so I understand there's a wide audience. But again, if you have any questions, put it in the Q&A, and I'm happy to answer it in real time. Or at the end, I want this to be most engaging for you and to sort of see what I'm thinking about, and then get your perspective as well as to how we can improve emergency department care. It is a stressful time and no one wants to be there. And we recognize that, I recognize that, and I'm working to improve that. And so this work centers along, this work centers particularly around care partners, around persons living with dementia, persons with cognitive impairment, and then how to improve those outcomes after the emergency department visit. Some disclosures, like Kristen had said in third bullet, we're funded fortunately by the Alzheimer's Association, as well as some other funders have chipped in as well to support this this work, and I'm very appreciative for that. So thank you. Brief outline. I want to keep this to maybe 25 to 30 minutes, recognizing that the discussion, the Q&A afterwards is oftentimes most beneficial as opposed to me just talking to you. But I want to share our work and then leave some time at the end to sort of hear your perspectives and hear how we can improve things from what you've seen. We're first in the first few minutes, I'll share a little bit of the background, which some of you probably already know, sort of cognitive impairment, dementia, some of the work that our team has done, and then some of the ongoing work that we're doing through this grant and what the Alzheimer's Association is funding. And then finally, we'll finish, before we get to questions, we'll finish with what the hope is for this work, and then where do we take this work? And I'd be curious to see where would you like to see the work go as well when you think about emergency department care. So who am I? I always think it's sort of good to start with this, and I just put a brief slide here. I grew up in Pennsylvania. I did undergrad in medical school there. I went up to, Kristen mentioned Rhode Island there for one of the studies. I went up to Brown. I did emergency medicine residency in Providence there. And then in 2019, I came down to Connecticut for a fellowship. And I've been here since now. So a little over 3 years. I did 2-year fellowship, and then I've been faculty emergency physician and researcher with the Department of Emergency Medicine since then. And my work centers primarily around the geriatric population broadly, particularly those persons living with dementia and their care partners. And then as well, sort of other buckets that I engage in are quality measurement and health policy. And we'll talk about sort of those things throughout the talk a little bit here. And then the final question I have on the slide is, where does my interest in these topics come from? And it's sort of a personal and a professional sort of combination. From a personal perspective, I'm sharing this just briefly because I always think it's important to understand the why of a person, and I really think that speaks to their motivation to sort of do the work. And so mine is pretty strong. From a personal perspective, a lot of my work deals with care transitions. Care transitions being what happens after the emergency department. How does the family member, how does the patient get back to the community and sort of link up with their primary care doctor, or link up with a neurologist, or link up with a geriatrician in the next step? And what happens in that time frame, in that care transition, in the interim time? And that personal perspective, my wife's grandmother had poor care transition where she was in the hospital. She was transferred then to a skilled nursing facility, and some medications fell off. And her heart failure worsened, and then she ultimately could not get hip surgery that would have improved her life, and she ended up passing a short time after. And so it was that care transition from the hospital to the rehab, and then sort of bouncing back and forth, that really sort of got me interested when I was an early resident up at Brown. Professionally, then I was seeing something similar. We would have patients come into the emergency department from nursing homes, and the story was lost. It went to that question in the Q&A that I saw from the Cohen plan, I think. They asked a great question about how to sort of go with the rescue team when their father needs to go to the emergency department. And what I would see is people would come from nursing homes and no one would be accompanying them. And it's unfortunate because I think that decreases, the care transition coming from a nursing home to the ED. The rescue team might not know exactly what happened or couldn't provide the exact details. I would call the facility back and the staff maybe changed hands. And so the new staff wouldn't necessarily know what happened. And sometimes the person themselves maybe had cognitive impairment and they wouldn't necessarily know the exact details. And so I felt like sometimes we did these big workups and we had to admit people potentially unnecessarily and potentially against their wishes or their preferences. And so that really sort of, from a personal and professional perspective, really sort of got me interested in this topic. And this is sort of where I've been for the last 3 to 5 years or so, and where I see my career being. By way of background, I think some of you probably know this, older adults, I think the stat is 10,000 turn 65 a day. And so the population is aging and they visit the emergency department. They visit on the tune of 22 million times a year to the emergency department. And those with cognitive impairment or dementia particularly visit a substantial chunk of that. A good chunk of those with cognitive impairment or dementia are actually discharged home. This number, it's somewhere between 50 and 60%, excuse me. But they're actually at risk for adverse outcomes in a greater extent compared to those without dementia, compared to those without cognitive impairment. So, they have greater functional decline, they have greater return ED visits. So they're really a particular population that's very vulnerable in this time period after an ED visit, as you can see. And the informal family, the family caregivers, the care partners, they're increasingly responsible. They're struggling with these decisions about is a facility the right thing to do? Can we get extra care in the home? Can we get extra home health? Can we get services or resources? How do we sort of navigate this? And they're sort of responsible during this time period increasingly. And so this work, the slide that I show now is some of the prior work that I mentioned on the outline. And this is sort of the first, when I sort of first dipped my toe in this research, and it was sort of this idea of nursing home transfer to the emergency department. And we identified that of that documentation, their usual mental status was absent 75% of the time. This is in like 500 patients. This is not a small sample. And their usual functional status was absent in 80%. And these are critical things that we as physicians, as clinicians, we're getting to know someone very quickly. We need to know quite quickly. Sorry, excuse me 1 second. I'm in an office here where I have an automatic light, and so it's motion sense. So I just need to move every few minutes. And so, like I said, these things are critical, and we need to know. And you can imagine for someone with cognitive impairment, they're vitally important. And it was actually worse. Those numbers were actually slightly worse, up in the 80 to 85% absent range. And so from this work, we translated this, we created a standardized form that we need as ED clinicians, and we sent this out to the local nursing homes. And this really sort of improved adherence and documentation of those critical elements that we really need to know. More recently, I know this is a lot of a slide. I don't want you to sort of read it individually, but I'll sort of share the big picture. I've had the pleasure of working with a multidisciplinary group. And that's called the GEAR Network, the Geriatric Emergency Care Applied Research Network. And this GEAR 2.0 version particularly worked with and sort of around issues of how emergency care interacts with patients with Alzheimer's, patients with dementia, patients with cognitive impairment. And so, like I said, this was multi-stakeholder, this was multidisciplinary. We had emergency medicine docs, we had nurses, we had community partners, we had persons living with dementia themselves, multiple, we had care partners, we had physical therapists, we had pharmacists, we had health equity representation. And it was this big group of 50 or 60 people. And we sort of targeted the key issues of the day. And my issue, so the one that I've sort of been driven towards, is sort of care transitions, what happens afterwards. And so we wrote a paper and we convened with, as you can see, person living with dementia, care partners in the third column there. And we said, what are the absolute critical things that we need to focus on going forward? What really needs to improve? What needs our attention right now? And across across groups, you can see that the top two were sort of, how do we improve outcomes? And then the second one, what are those outcomes? What really matters most to those people with impaired cognition and their care partners? And how do we sort of identify those outcomes, and how do we identify those measures? And that sort of is sort of a bridge to sort of where the work comes in, where the ethos and sort of mantra that I live by is you can't improve it. You can't improve something if you're not measuring it. And so the first step in some of this work that I'm going to share is sort of developing the measure. We need to make sure that what we're measuring actually captures what matters to persons living with dementia, to care partners after an ED visit. So how do we identify what matters? And so it's through these multiple steps. Once we identify what matters, then we can improve upon it, which is sort of the pie in the sky, the idea down the road. And so the Alzheimer's Association, Kristen had mentioned, put out this grant about a year and a half ago now. And this is the one I applied for. And I really the idea was to advance research on care and outcome measurement. And that was sort of my who I was, who I am. And it really, this mechanism, this grant really spoke with me. And so I was really appreciative when this grant came out. And the third one is sort of where I sort of saw myself and saw the work going, developing and evaluating quality metrics that are meaningful to the stakeholders that matter, including those underrepresented populations, as Kristen mentioned. And so this gets into the science a little bit. We can go as far in detail as you like, and we can stay as high level as well. But this is sort of some of the science as to what I want to do. And what it ultimately comes down to is to develop what's called a novel outcome measure. And so what a measure is essentially a questionnaire. You could think of it as a questionnaire or a survey, where that outcome measure is maybe 15 questions about what really matters. And you'll see some examples in the coming slides. But the idea is, what are those questions, and how do we identify those questions that really matter? And then how do we track them and improve upon those outcomes? And so at the bottom of the screen, you can see the name, the acronym I came up with for this tool, and it's called the Caregiver Reported Outcome Measure for Emergency Care Transitions. That's the COMET tool. And so the COMET tool, our aims, the work that we proposed was to develop the tool, and then to validate the tool, and then to sort of see how the tool is associated with ED visits after ED care. This is a brief flow diagram here that it's sort of meant to be a signpost that I'm going to come back to in the coming slides. But this sort of just shows the research sort of flow as to how things worked throughout the process, recognizing that the end product at the bottom, the COMET tool, is a process that takes 6 phases or so, as I've outlined them. The way logistically that the research worked was the research assistant talked to the emergency department clinician, and they saw someone who was older than 65, 70, 75 years old. And they asked the clinician, do you think this person has a greater than 50% chance that they will be discharged? Because we're really we care about all patients, but we particularly care about those at risk for the vulnerable care transition back to the community. And so we had what's called a purposeful sampling matrix, which we sampled patients based on race, based on ethnicity, based on gender. Kristen had mentioned earlier, one of the important components of that African American and Latinx older adults are at increased risk of dementia. But the unfortunate thing is that they oftentimes do not carry a diagnosis in the electronic medical record, which is critical, because then they and their care partners, their family members, cannot get the services, the resources, the referrals if the diagnosis or the information is not known and present in the electronic medical record. So we really tried to sample and engage older adults, and we screened. We did cognitive screening in the emergency department, brief quick assessments that suggested if, hey, maybe this person has cognitive impairment, but it's actually not recognized in the medical record. And so we really wanted to address that to sort of create this diverse population, because a lot of the Alzheimer's and dementia research, is on the order of 90 to 95% white populations, which isn't representative of the population we're trying to improve their care for. So we really had an intentional effort towards that. The first stage in the research, you can see in the top right corner, is what's called qualitative interviews. And qualitative interviews occur when one of the research assistants, the RA, picks up a phone and they talk to the care partner maybe 3 to 7 days after the emergency department discharge. And they say, what did you experience after the emergency department? What worked well? What didn't work well? How do you wish things would have went? What could have been made better? How could we improve? And sort of what have you experienced? And so we did that with 25 care partners already. And that's why we have a green check mark, which I'll show you sort of some of the results in these slides. And this work was actually just fortunate to be accepted for publication in one of the Alzheimer's Association journals. So we're fortunate to that, and the work we've collaborated on with some of the care partners in and around New Haven here. There's 4 themes that we identified of that care partners experience, particularly after an emergency department visit during that care transition. I'll show 2 here, and then I'll show 2 on the next slide. The first one on the left is sort of what happens in the emergency department setting itself, and how does that impact the care transition afterwards. If anyone's been in the emergency department in the last 2 years or so since COVID, you recognize the COVID-19 visitation policies. And these are some of the themes that sort of came up in these conversations, in these telephone calls. And that absolutely hinders the success of what happens beyond. And are emergency clinicians, emergency nurses great at calling care partners, calling family members? Always? No, they are not. And that's sort of what we found out. And we can imagine that, and we see that sort of but it is vitally important. And then sort of, if no one is present during those visitation policies, another thing we saw care partners say is, hey, my family member, my friend, they have a potential to downplay their cognitive impairment. That, they're gonna, brush it off. They're not gonna sort of, if it's not in the medical record, they might not display it as much. If someone else were there, it might not be picked up, which is a shame, and stuff that limits that success of the care transition. And so there are a few quotes that might resonate at the bottom there regarding that. She puts on a good front until you talk to her long enough, kind of thing. Some of these things that really came out. Building on that, then, and like I said, if any of you had the misfortune to have one of your family members or yourself be in the emergency department, there was a poor communication and lack of care partner engagement, and especially during the discharge process. Oftentimes the discharge process was seen as abrupt. You sort of get a packet of papers, this lengthy discharge paperwork. You see one of the themes. And there's no real explanation of what happened, what the testing was, or like what the next steps are. And family members or care partners, oftentimes really on that last bullet, they're really desired some sort of follow-up phone call, some kind of follow-up contact as they sort of waited for the next step. They sort of just wanted to make sure that things were going as planned. If they had any questions, they really didn't know who to contact. They were sort of left in this no man's land, they felt. And one care partner at the bottom said, we never got a call back to say, we think it's X, Y, and Z. I think that would be one of my considerations that maybe needs tightening up, is more communication with the family. And I couldn't agree more. You can never communicate too much. I would think the vast majority of problems result from a lack of communication. The last 2 themes here that we sort of picked up in these telephone calls were related to care partners and then the subsequent navigation of the healthcare system, which is daunting in and of itself. And so care partners themselves really experience some challenges as their family member, their friend, their person, they're with cognitive impairment or with dementia, as they're navigating this acute illness and recovering and sort of doing this. The care partner might have, we saw, and they identified feelings of guilt. They had feelings of obligation. They tried to enhance the in-home safety. And they oftentimes found that, if their family member or their friend, they fell, they broke their clavicle, they broke their arm, the increased assistance, the ADLs, is called activities of daily living. And so while they were already probably caregiving and helping them a little bit, now during that recovery, during that care transition, this really escalated for a significant population of those with cognitive impairment. I'm helping her more as far as total care. Her walking is not the same as it was before, so she's needing more assistance now. This is sort of speaks to that theme. And then finally, the final theme is sort of navigating the healthcare system after. It's perceived as difficult, understandably. Sort of you can see the quote at the bottom. How do I get her some other assistance? Where can I just call and ask, is this normal? Is this really off the wall? That would be a great thing. And it's sort of these themes here, the primary care coordination. Can I get respite care? What are the steps? Christmas was sort of talking about blood tests. Sort of how do I go about getting formal testing? I recognize that she has, as a family member, I recognize that he or she has cognitive impairment. What are the next steps? What do I do? The ED is oftentimes seen in every sort of healthcare setting has its purpose, but the ED is sort of answers a specific question. Do you have a heart attack? Do you have an obstruction in your belly? Is there a broken bone? And then sort of hands done, out the door. I sort of want to change that paradigm, that we can do better to connect people, to connect care partners to the resources that they need. I think that that's critical, because it is oftentimes this sentinel event, this touch point of the healthcare system that's so critical. The next steps. So once we did those telephone calls, we got a lot of great feedback. And we got a lot of information. And I'm just going to show the next step in sort of developing the questionnaire, the COMET tool, is to sort of put together those themes and those quotes, look at the literature, and then look at what questionnaires are out there already to sort of come up with questions that we think are important. And so just to sort of show you sort of what I mean by a COMET tool, the COMET tool would include some of these questions that you can see on the screen. For example, the care partner would answer this question. I received answers to all my questions during my family member friend ED visit, or I have remaining concerns that were not addressed enough during my family member or friend's ED visit. Those are candidate questions that might make it onto the final COMET tool. In this step here, what we did is we wanted to get information from care partners. These are the questions that we thought up based on the telephone calls, based on all the information. How important do they think it is for that question to be on the final tool? So on a scale of 1 to 5, we said, care partners, hey, do you think that this is not important, or do you think that this is super important to be measured? Because if we're measuring it, then we can improve upon it. And so you can see, just for example, 3 questions here. There were a total of 50 that we put out to a wide group of care partners to quantify, to say, how much does this matter? How important is this? Because at the end of the day, we want this to be entirely stakeholder driven. We want persons living with cognitive impairment, and particularly the care partners, to drive the ship. That's the most important part. So we had a list of 50 questions that ultimately, that we had a lot of quantitative information. The next step, which is also completed, of the 6 phases, we're done with 4. And this step is called cognitive debriefing. So we had this list of questions, and we said, we again talked on the phone with care partners, and we said, what do you think of this group of questions? How is do you comprehend them? Does it make sense? Would you change any words? Could any be removed? Should any be added? And again, it's just another touch point to go back to care partners, another group of care partners, and say, which of these needs to change? The final phase, which we're actively working on now, and actually the meeting tomorrow to sort of move this forward, is called a TEP. And a TEP is a technical expert panel, where we gather experts from around the country, geriatricians, dementia doctors, neuropsychologists, emergency medicine doctors, nurses, again, care partners, again, persons with cognitive impairment. And we present those 50 questions, and we say, this is what we're thinking about based on the information we have received. These are the questions that we think should go into the final COMET tool. And we ask them to agree or disagree. I think that based on how strongly care partners had that first item, they had a score of like 4.7. I received all my answers to all my questions. I suggest that we should retain that in the final tool, that should be included. And then we ask them if they agree or disagree. And we did that for all 50 questions. This is a lengthy slide, and what it is, it's the culmination of those 50 questions, and which ones, based on the high scores from care partners, based on the interviews, which ones we really think should be included. And this is a dynamic, evolving process actively right now. And I don't want to go through each one, but this is sort of the flair. If we measure these things, which are important to care partners, can we improve them going forward by introducing interventions, by introducing things? Because if we're tracking it, we can improve upon it. The final phase of this then is, once we get that final tool, that final comment tool developed, and we have those questions that we really think are important on a survey, then we roll it out to 150 care partners and we ask them, how did your emergency department visit go? And then we test them again at 14 days to see the reliability of that. I touched on this a few times throughout, but the impact is that and you all have probably experienced this, the emergency department discharge, I think we can agree is suboptimal oftentimes. I said it's abrupt, it's oftentimes next steps are sort of lacking, and the hope is that this can really improve those conversations, and we can incorporate some of these findings into that discharge process. We can identify if the priorities of care partners are being met. And in red, we can also inform subsequent intervention. So we get this measure, we know what we want to track, we know what we want to survey. Now we can introduce things, educational tools or interventions going forward to improve those scores and get care partners, get persons with cognitive impairment, the resources, services, education, knowledge, the things that they need at the point of care. Just sort of coming down the stretch, I haven't looked at the Q&A, but we can go there. But I would be remiss if I did not thank my team, folks at Yale, folks around the country as well, sort of experts in outcome measures and survey development, and the real boots on the ground, people that are in the emergency department doing the enrollment, talking to care partners. And so I am very appreciative to the team and Alzheimer's Association for funding this work. I'll stop there. And like I said, I want this to sort of be a conversation and how we can, what you think about the work and how it can be improved. So again, an absolute pleasure to be here, and I look forward to the questions.
Thank you very much. And I apologize that I've been pronouncing your name wrong the whole time. It's like kettle chip, isn't it?
That's what I say. Yeah, that's what I say. It rhymes with kettle. That's
all right. Thank you. Yeah, there's a bunch of questions coming through, and some comments as well. You know, talking about. So Patty says something about delirium can be transient. It's unclear its relevance as a coded diagnosis. So this is obviously a professional, a transient issue. So you want to talk about delirium a little bit and how that may mask some of those questions that you're asking, or?
Yeah, that's a great question, Patty. And we recognize delirium can be isolated. We recognize dementia can be isolated. We recognize that they can be delirium with dementia, dementia with delirium. And so we're not relying on a code for delirium. One of the screening techniques that we use is the research assistant uses first is called the 4AT, and it's an abbreviated test that sort of identifies if delirium is present, because like you said, it's a transient issue. And so we don't necessarily want to capture people with isolated delirium that is going to resolve. And so one of those screening tools picks up, is this person have delirium, at risk for delirium? And if they are, then we really want to focus on those without delirium, but with more long-lasting cognitive impairment that can be picked up on the AD8, one of the other screening tools that we use. And so we sort of do both of those tools to sort of split the best we can. There's no perfect split. There's obviously a lot of overlap, and it's not perfect, and we recognize that, but we do our best with those screening tools. So great question and absolute important issue. So
Bill says his wife had 2 ED visits the past 5 months, home until the first visit, hospitalized. He was talking about Yale and Harvard Healthcare. I have this My Chart that can follow the daily care. And then he was able to figure out, I think this is more the comment, it was able to help him make a decision by following. So that follow-up in that regard helped him to make the decision that she needed to be placed and needed more care than he could provide. So I guess it's almost like showing that the importance of follow-up and transparency with the caregiver, I guess.
Absolutely. Yeah. Bill, great point with My Chart. And I think that is some of my work going forward. I didn't allude to this now or talk about it now, but my work in the future hopes to harness the power of My Chart, of some of those digital health opportunities, those technology with care partners to keep them informed, to keep them engaged, to help them out after the emergency department visit. Because like you said, with My Chart, you can track in real time. Okay, was the x-ray done? Are the labs back? Was there a consult order? Did social work see them? Did case management see them? What were their recommendations? And then you can track those things and act on those. And your primary care doctor or someone else integrated in the healthcare system can then communicate with you via My Chart as well. So it definitely offers a lot of power going forward, and accessibility. Not everyone has my chart and the accessibility of that, which is another issue, a discussion for another day. But one that I think us as a healthcare system should embrace and move forward. It's a great comment.
The Cohen clan who come on a lot of these with us, and we're so excited because they just continue to educate themselves, which is really quite amazing. Talking about, is there a question ever asked that the goal of a caregiver visit? Can some discussion be had outside the door or while the patient is wheeled away, right? I mean, that's such a question, don't talk about the person in front of the person. Oh, they can't talk, they can't hear us, but they do hear. And sometimes they understand, even though they can't verbalize that they're hearing what you're saying.
Absolutely. That's a great point. And I absolutely take that into consideration when my research assistants go into the room. They'll talk to the patient, they'll engage with them, do any screening that's needed, and then talk with a care partner. I teach them to go outside the room, talk with them, talk about follow-up, contact, telephone information, all that stuff. Again, because like Kristen said, you don't want to be talking in front of the person about the person. And so we do that. As for the broader perspective outside of the research, as to like everyday emergency department care, and I can't speak for all my colleagues if they all do that. I definitely try to do that when I'm practicing clinically. I think it is a great point and a great practice. But I can't say if everyone does that just in the essence of time, which should be the gold standard, as you suggest.
Right. Your research speaks of the need of EW to have a special line to call to discuss caregiver concerns prior to admission. Could that same line help with discharge plan or questions after the person is back to the residence? I guess that's part of what you're looking at, right? Is like, what is the best way to do this follow up?
Yeah, and I'm apologize. I'm less familiar with EW line.
Yeah, I'm not sure either what EW is. Maybe Michelle can make another comment on that.
I'm less familiar with EW line, but yeah, I mean, it does go to the discharge planning, and so much of it, I feel like reflexively, and I don't know if you have experienced this, oftentimes reflexively, emergency medicine doctors are caught between a rock and a hard place, and they don't necessarily think that the person is potentially safe to go back home. And so oftentimes then we have to admit the person to the hospital, and that the hospital doesn't come without risks. I think, as you're suggesting, there's functional decline, there's infection risks. And so having something like that, a caregiver line perspective before the admission, if I caught what you were saying correctly, that is a pivotal point in the healthcare sort of trajectory right at that point. And so any kind of information before that decision is made is critical. And to get all parties, yourself, the clinician, the person with dementia, at the table, and sort of what is best. Oh, okay, I can go home, or they can go home. They can go home with me. Wonderful.
Yeah, and she was saying EW is ED, emergency ward.
Oh, okay. Oh, I'm sorry. Oh, yeah, W is near D. I didn't see that. Sorry.
Yeah, and I think this talks about a lot of things we do, and let me just put this plug out. We are always looking for volunteers to assist, and we have a lot of volunteers who do community education. I'm not sure they'd be able to do this in particular, but there's also obviously a huge need for education about dementia to everybody, ER. I mean, we do some grand rounds, that kind of thing, but there's such turnover in an ER too, right? So every time you would train a whole entire staff, and then like an entire other staff would come in. So there just needs to be obviously more awareness of one of these signs of dementia, et cetera, and how to deal with someone with that, but also talking about in resources, right? I mean, giving the Alzheimer's Association helpline. I mean, you and I have talked about that, and just on their way out.
Yeah, I can just expand upon that, Kristen, if you don't mind. One of the things that I'm looking at for my next work is thinking about how to connect care partners with those resources. And I've talked with a few folks at the Alzheimer's Association, and there's a tremendous resource, and I pardon the plug here, but the community finder that the Alzheimer's Association has on their website has an abundance of connections to geriatricians, to adult daycare, to respite care, to attorneys, to all kinds of services, to diagnostic testing. And so I really thought that's a really wonderful resource that I did not necessarily know about, and maybe someone on the call doesn't know about it, and that might help them in their local community, because it's tailored to the local community, which is really remarkable.
Absolutely. And then maybe somebody could put our 800 number. One of my folks could put our 800 number in the Q&A for folks as well. Someone was asking, going back here, that what would you see as have been your wife's grandmother's ideal situation, right? What would you have liked to turn that around to if we could do it again?
Yeah. So the backstory with her was that she had heart failure. She had hip arthritis, and she needed a hip arthroplasty. She needed a hip replacement. And so she had a heart failure exacerbation. She was in the hospital, and then some of her heart failure medications fell off. In the transition to the skilled nursing facility, the facility was not giving them. And so she was still functional. She was cognitively functioning okay. She was physically functioning okay. But then that sort of just spiraled, and then it was a hospitalization after hospitalization for heart failure, and then they deemed her not stable enough for the hip surgery, and then ultimately she passed away a few months later. So I mean, I think the ideal would be making sure that bridge from, in this case, hospital to skilled nursing facility, that care transition is sound, is airtight, because that transition, this care team knows her so well. This care team doesn't know her yet really at all. I mean, and so making sure that is airtight, all those medications are on board, to ensure her quality of life is the maximum that it can be at that time, I think is what I would have hoped for at that time.
Let me ask you this. I mean, there's some suggestions, some people put in suggestions that they thought that would be helpful in the air. For going forward, what are some things that you can suggest people can come in with to make this easier? I know you're working on your research and you're creating this tool, and it's not going to be available tomorrow in case there's an incident tomorrow with one of these folks. But what can people do as their own advocates coming into and out of this situation?
Yeah, I mean, I think that's a great question. And it's just sort of knowing your preferences and sort of being forthright and having the foresight to have some conversations ahead of time. I think, you don't want, no one ever plans for an emergency department visit. And oftentimes what we see is someone comes in and, they're critically ill, or we want to know about goals of care and those kind of preferences as well. The other issue that we oftentimes see is, the person, they haven't really had the conversation about the living situation. Are they living with their children? Are they living with their spouse still? Are they doing an independent living? And I think sort of having some of those conversations, they're not fun to have, but just bringing some of those thoughts at least to the table, as to how you're managing as a care partner, as a person with dementia or cognitive impairment at home. I think the more that you can have foresight as to those ahead of time coming in, and then when that moment hits, you're prepared to say, me and my siblings, we've talked about this. This is what we think for mom. This is what we think for dad. This is what should happen. In the case that's something, in the worst case scenario, if you will. No one wants to think about that ahead of time, but we always appreciate family members that sort of, can voice those preferences, because I want to do what is in line with your preferences. I don't want to hospitalize your mom, your dad, your sibling, your spouse against their wishes, against your wishes. I want everything in my power to get them home, to be with you. And so, just having a sound, robust plan aligned with your preferences and their preferences is the best thing that I think could be done ahead of time.
You guys, because we don't have the chat option, we have the Q&A. We're gonna, all those links that we put in there with the 800 number and the alz.org/CRF, the community resource finder, etc. We are going to send to you when we send up the following. So we send a follow-up email with a recording of this. So the links, if you're not jotting them down right now, we're going to send them to you. Thank you, Stacy, for mentioning that. Stacy's going to send that to you moving forward. Dr. Gettel, I would like to, if you could chat a little bit about, because I'm not sure people understand. I know there's different ways to utilize this money, but how will the grant money, is this so that you can add more people to ask the questions? Is this where
does the money go, kind of thing? Yeah, so the money goes to a few places. The money goes primarily for patient incentives to participate in the research. We recognize that this is time out of your days, and so any participants that we have in the research, we compensate for their time, for their energy. We also support the research staff who does the questionnaire, so their salary is paid for, or partly paid for. Part of my salary is paid for. So big picture, and this is probably too much in the detail, but if I get a grant and I can cover part of my salary, then I work less clinical shifts, and then I can do research to move this forward. And so that's sort of how research and academics works. And so part of it funds my time so I can sort of think about these issues and think about how to improve them. There are other than parts as well. Some of the funds as well go to getting the research out there. So disseminating we want to disseminate the research. That's a big part of it too. Our findings are important and we want other people to know and sort of think about them and comment on them and implement them in their own way. And so part of it then is sort of getting this work out there is another component of some of the funds.
I think it's also important to state that, all the different grants that are given, and they're given in different forms and different amounts of money and different years and different types of grants as well. Again, you can see that on the Science Hub app if you guys want to take that app down. It's really about, it's the second time I'm using this word today, but transparency. I mean, they're checked in. This is not, here's a bunch of money, we'll check in with you 3 years. Oh,
yeah.
I mean, you have to report things. You have to, is like, here's data in case, this is great because this is in case someone else doing a caregiver study somewhere else can utilize your data.
Oh yeah. The money is very, from a nuts and bolts logistics perspective, the money is very well explained. For example, in the grant, I have to explain exactly what I'm going to do with every penny that I request, and then that is reviewed by the committee, the funding committee. And then if I want to make any changes that after the fact, I need to seek their approval. And so every dollar is accounted for, and like Kristen said, it undergoes scrutiny and making sure that the dollars go where we want them to.
Yeah, and so that's wonderful. Is there anything else? I think we're almost at time. So is there anything else that you would like to add as we wrap this webinar? And we're so grateful for your time today.
No, I mean, I just appreciate the platform to sort of talk about some of this work and hear the perspectives from the boots on the ground, the people that matter most. And so I am sincerely appreciative of the Alzheimer's Association and this opportunity to talk with you all.
Well, thank you very much. Thank you everyone for coming today in the middle of the day. And we are very excited that, I like to say this is where the money goes, talking about the money that you raise is really going towards our local researchers and really to push this forward to help in all aspects, not just drug development, not just looking for, like I said, something towards a blood test or looking at different MRIs or CAT scans and advancing those kind of things, but also advancing the caregiver experience. So we really appreciate all that you guys do in helping. And if you'd like to volunteer and join us in any way, shape, or form, again, that our walks are coming up very soon. And again, thank you very much to Dr. Gettel, and thank you all for joining us. And we hope that you have a great rest of your day. And we're coming up on a holiday weekend, aren't we? So have a lovely holiday weekend, everyone, as well. Thank you. We still have a few people on, but I just thought it was, it's wonderful that all these questions are being asked. And also I just wanted to stress, if they're still on, the people are wondering how to join a walk, and it's alz.org/walk. And you can just put in your zip code and you can find one that is close to you. So that's wonderful. I'm actually gonna stop recording right now.